Assalamu alaikum. Today I will talk about, I have published a paper 2 years ago, and I use it now for my field. Is like I start to do spine endoscopic surgery. The introduction, as we know, the endoscopic spine is about mobile operating tube. It's we have to select the case for the spine endoscopic as spine intervertebral disc prolapse and central disc herniation, or foramen or extraforamen disc herniation, or also we can also what's the most difficult for the choosing for the spine endoscopic is spine canal stenosis. Also we do by spine endoscopic also inserted interbody cage and bone fusion in implant. This technique I started from this year. It's like I maybe around 85 case. Single level is about 81, and two level is about 4 cases. The endoscopic advantage is a mobile system, and it is give us a clear and explore hiding recess and perfect quality vision. And we can see also its our eyes is particularly inside the spine. And also it's have special design to see the surgical instrument. Why we choose spine endoscopic? There is a photo like spine endoscopic is about like a target missile. We go to our target, but either one, the other surgery is like a blindly explosion bomb. The patient benefit is like most of our patients, we do it local anesthesia, small incision, less muscle and bone trauma, less post-operative pain, and fast resume to life or physical activities. And also the most of one is reduced rate of infection, especially here in our hospitals in Yemen. And the most advantage is also for obese or fat patient. The technique, the spine endoscope is about nerve rotary tractor and channel for the lens. We have in spine endoscopic 3 approach. The first one is interlaminar endoscopic. I give you a brief. This, as you see, is have clarification before the surgery. It says we use the drill during the surgery, and this is, as you see, that we remove the flavium ligament and the disc. This is post-operative the disc, as you see. And also we can use it in cervical. This is, as you see, is like a foramen disc prolapse. We can go through the interlaminar from the behind. We call this surgery is like keyhole surgery. As you see, this is the nerve root is free. This is the hole. We called it keyhole surgery. The second approach is transfemoral endoscopic. Transfemoral approach. This is, as you see, is big disc, 3-4 leafal, totally like stenosis the canal, and we can get it by 1 fragment during 30 minutes surgery. This is the approach. As you see, we go from the transfemoral. Sometimes we go 8 centimeter to 10 centimeter. This is about a brief video to see the transfemoral approach. This is this is a recurrent post-open surgery and have a recurrent disc. You can see we do it by local anesthesia, and patient can move during the surgery. And this is I use now the RF, what called it radio frequency, to remove the adhesion tissue. This, as you see, we can remove the adhesion tissue, and now you see I go inside the inter disc. Now you see this is the disc, and this is incision. It's only not only maybe half centimeter, small incision. The patient after surgery go without antibiotic. Maybe sometimes we give them amoxicillin post-operative. This is the last approach, or the third approach is unilateral biportal endoscopy. We use it like same in orthopedic arthroscopy. They use one channel for the lens, one channel is for the working tube or sit. I give you some brief. This one case I did it in Aden. Maybe 65 years old. The patient, she was diabetic and obese patient, and she have heart failure. And this is like actually is for this case it's a difficult case to choose transfemoral approach or interlaminar approach. So I chose the unilateral biportal endoscopic. As you see, the canal is severe stenosis. No. As you see, I use also the drill to dissect the interlamina. This is the contralateral nerve root, as you see, not my side, contralateral approach. The patient was post-operative totally relief. So I know many of you will ask me when to decide to do endoscopic or when to decide to do fusion. We do the endoscopic if the patient have friction, back pain, or effective block injection. Sometimes I do block injection to the patient before the operation. If the patient, okay, they say he's relieve the pain, so I can do the endoscopic surgery. So when we don't do it, the patient have extension back pain or anxiety or depression, maybe a lot, not only endoscopic, maybe also open surgery. We have to far away from the depression patient sometimes. And have also, if the patient have intervertebral joint instability or recurrent chronic pain. Result, most of the patient was improving immediately during the surgery or post-surgery. I have one recurrent case post 2 months of surgery. The conclusion, this study results suggest for the patient who suffer from the disc or have back pain, the endoscopy surgery is a good choice for them. My future plan, maybe for the next year, it's the spine robotic surgery. I'm planning to do maybe next year we will develop the spine surgery in Yemen, like we will bring some machine to do the implant. This is the robotic surgery. As I work it, no. Can't video. Okay.
Thank you, Dr. عصام.
This is, as you say, is robotic. There's a one.
1 minute.
Okay, it's enough. The video is about we do this is totally by robotic surgery without hand. It's like we see it hand free. We collect the patient's CT before the operation with the robotic surgery, and we do it like as you see Brook-Tennis screw. This is we do it by Brook-Tennis, and we insert the cage from the transfemoral approach, and we remove the disc and inserted the cage fusion. As you see, this is we do 6 screws. Thank you. Any question, please?
Thank you very much, Dr. عصام.